Bismillahirrahmanirrahim. Assalamu alaikum. So today we are going to continue the muscles of the anterolateral abdominal wall. So let's continue with the rectus abdominis. Now what is the basically origin of rectus abdominis? So rectus abdominis originates from the symphysis pubis and the pubic crest. Symphysis pubis is the point where the two pubic bones meet, okay? And its insertion is on the 5th, 6th and 7th costal cartilages and the xiphoid process. So these 2 points are the insertion of the rectus abdominis. Now about the nerve supply of the rectus abdominis, the rectus abdominis is supplied by the lower 6 thoracic nerves like all the other 3 muscles, but it is not supplied by the L1 nerve, that is iliohypogastric and ilioinguinal nerves, that are absent in case of rectus abdominis. And its function is also same. It compresses abdominal contents and it flexes the vertebral column. That means it helps in the rotation of the vertebral column by compressing our abdominal viscera, and it is also an accessory muscle of expiration. Okay, now let's see the rectus abdominis in further detail. So the rectus abdominis is a long strap muscle that is extending along the whole length of the anterior abdominal wall. Now let's visualize this from a picture of atlas. Here you can see in this diagram that actually the rectus abdominis, it is originating from the costal cartilages, 6th, 7th and 8th costal cartilages, as you can see, and it is extending up to the pubic tubercle, or you can say up to the level of pubic symphysis. So this is this long strap muscle, this muscle specifically here, the red muscle you can see with several intersections. This muscle, this long strap vertical muscle along the whole length of the anterior abdominal wall, this muscle is called the rectus abdominis. And when this muscle contracts, its lateral margin, as you can see, this margin is called the lateral margin. This lateral margin of the rectus abdominis, it forms a curved ridge when the rectus abdominis contracts, and it forms the linea semilunaris. And the linea alba is actually the line where the both opposite side rectus abdominis muscles from both the left side and the right side will meet together in the midline. That midline line is called the linea alba. But the lateral margin of the rectus abdominis is called the linea semilunaris. Okay. Now the rectus abdominis muscle is actually divided into distinct segments, as you can see, by 3 transverse tendinous intersections. Here you can see this whitish region is the transverse tendinous intersections, and these are actually 3. So we have 3 transverse tendinous intersections, and that intersections are actually strongly attached to the anterior wall of the rectus sheath. Now the rectus sheath, we will see it in detail after that. Okay. Now these transverse intersections, tendinous intersections, which you can see, these are actually, when they are well developed, they lead to the six-pack abs appearance, the classic six-pack ab appearance, which you usually visualize in the people which have good tone of muscles, okay, and which exercise regularly. So this muscle is well developed, and these transverse tendinous intersections give the classic six-pack ab appearance. Okay. Now the rectus abdominis muscle, this rectus abdominis muscle, as you can see, this rectus abdominis muscle is actually enclosed between the aponeurosis of the external oblique, internal oblique and the transversus abdominis muscles, and all the aponeurosis of these 3 muscles are actually going to enclose this rectus abdominis muscle. And around the rectus abdominis muscle, when these aponeurosis of these 3 muscles, external oblique, internal oblique and transversus abdominis, when they will enclose the rectus abdominis, they are going to form a sheath. That sheath is called actually the rectus sheath. Okay. Now we have been familiar with the rectus sheath in the rectus abdominis part already. But before digging into the further detail of the rectus sheath, let's discuss our last muscle, that is the pyramidalis. Now the pyramidalis muscle, it is actually a small muscle that lies in front of the lower part of the rectus abdominis muscle. But it is usually absent, and it is usually absent because it is actually considered the rudimentary or vestigial structure that is lost during the evolutionary process. Okay, and its absence does not causes any physical or functional deformity. But if it is present, then it is going to be originating from the anterior surface of the pubis, and it is going to insert up into the linea alba, and its nerve supply is the T12 nerve, and if it is present, it is going to tense the linea alba. Okay. Now let's dig into the further details of the rectus sheath. As we have already discussed in the rectus abdominis part, that the rectus sheath is actually formed by the aponeurosis of the external oblique, internal oblique and transversus abdominis muscles. So the rectus sheath is actually a long fibrous envelope that is going to enclose the rectus abdominis muscle and the pyramidalis muscle if it is present, and thus the sheath has two walls. One is the anterior wall and the posterior wall, because if something is going to enclose some muscles or something, that means it is going to be enclosing it from the anteriorly and also from posteriorly. That means it is going to have one anterior wall that is going to be present in front of these both two muscles, and there will be one posterior wall that is going to present behind these the rectus abdominis muscle. Okay, now it also contains the anterior rami of the lower 6 thoracic nerves and the superior and inferior epigastric vessels and lymph vessels. Okay, so here they are talking about the contents of the rectus sheath. You can jot down this specific point about the content of the rectus sheath anywhere on your notes or on your book, that the contents of the rectus sheath are, I am going to repeat this point, that the contents of rectus sheath are the two muscles that are rectus abdominis and pyramidalis, that if it is present, and the two vessels that are superior epigastric artery and vein and the inferior epigastric artery and vein. That means generally we can say inferior epigastric vessels, and the lower and the nerves that are the lower 6 thoracic nerves, and lower 6 thoracic nerves are from T7 to T12, out of which T7 to T11 you already know are called the intercostal nerves, and the T12 nerve is called the subcostal nerve. So these three things, muscles, nerves and the vessels, these are the contents of the rectus sheath. Okay, now let's dig further. Now to make this rectus sheath easy to understand, we have actually divided the rectus sheath into 3 levels. Okay, so one level we will consider above the costal margin, and one we will consider above the arcuate line, that means between the costal margin and arcuate line, and the third level we will consider below the arcuate line, that means between the arcuate line and the pubis. Now what is the arcuate line? You will know it. You will know about it when we will discuss it further. Okay. Now let's start above the costal margin. Now, so above the costal margin, the anterior wall of the rectus sheath, that is going to cover the rectus abdominis muscle, is going to be formed by the external oblique, and posterior wall, in posterior wall we are going to have the thoracic wall, that is formed by the 5th, 6th and 7th costal cartilages and their intercostal spaces. Now you will ask me that where is the internal oblique and the transversus abdominis aponeurosis. So above, we are talking actually above the costal margin, and above the costal margin we do not have any origin or any presence of these two muscles, internal oblique and transversus abdominis. There is only above the costal margin only the external oblique is present. That's why the anterior wall is going to be formed by the external oblique, and posteriorly we are going to have the posterior wall is going to be formed by the thoracic wall. Okay. Now you can further visualize this from this diagram of Snell's, that here you can see this muscle is called the rectus muscle. Here that dark brown color is called the rectus muscle, and above or you can say in front of the rectus muscle you can see the green color, that is actually the aponeurosis of the external oblique. So the aponeurosis of the external oblique is going to form the anterior wall of the rectus sheath here, and posteriorly you can see are the 7th, 6th and 5th. These are the costal cartilages present, intercostal spaces and intercostal muscles are present between them. So this is here at the above the costal margin, the posterior wall is going to be formed by the intercostal cartilages and the muscles. Okay. Now coming at the second level, that is between the costal margin and the arcuate line, that means it is about at the level of anterior superior iliac spine. Okay. Here you can see in this picture of atlas that this muscle is called the rectus abdominis. As you can see, this is the rectus abdominis of the opposite side, and in the center we have the linea alba here. Okay. And in front of this you can see this is basically the rectus sheath. This area which is enclosing the rectus abdominis muscle, this sheath is called the rectus sheath. Now here you can see the anterior wall of the rectus sheath, that means in front of the rectus abdominis muscle there is the aponeurosis of the external oblique. As you can see, this muscle is the external oblique and its aponeurosis is coming in front. But here is a point, that internal oblique aponeurosis, as you can see that near the rectus abdominis, lateral margin of the rectus abdominis, the aponeurosis of the internal oblique is actually dividing, and one layer is going to form the anterior wall of the rectus sheath and the other layer is going to form the posterior wall of the rectus sheath. And then again the transversus abdominis muscle aponeurosis is going to form the posterior wall of the rectus sheath. So that was between the costal margin and the arcuate line, that means it was above the level of arcuate line. Now let's move to the third level. Now at the third level, between the level of arcuate line and the pubis here, okay, that means below the arcuate line, you can see the rectus abdominis, and in front of the rectus abdominis we have the aponeurosis of all the three muscles, external oblique, internal oblique and transversus abdominis. All the three aponeuroses of these three muscles are going in front of the rectus abdominis. That means below the arcuate line, the anterior wall is going to be formed by the aponeurosis of all the three muscles. Then where is the posterior wall? So actually the posterior wall is absent. Here below the arcuate line, the posterior wall of the rectus sheath is absent. Okay. So if the examiner asked in exam that if below the level of arcuate line, if the posterior wall of the rectus sheath is present, then you are going to say the posterior wall of the rectus sheath below the level of arcuate line is absent or deficient. Now then what is you can see beneath the rectus abdominis. So you can see beneath the rectus abdominis we have of this red color a fascia, and this fascia is called the transversalis fascia, which we are going to discuss inshallah in the next lecture. So but remember the transversalis fascia is not forming the posterior wall of the rectus sheath. Rectus sheath is only formed by the aponeurosis of the three muscles. So if these three muscles aponeuroses are not present in the posterior wall, that means the rectus sheath posterior wall is absent or deficient. Okay. Now there is some other point that needs to be discussed, and that is about the arcuate line. Now you can note that where the aponeurosis that is forming the posterior wall now is passing in front of the rectus at the level of anterior superior iliac spine, and the posterior wall there has a free curved margin, curved lower border, and that curved lower border at the level of anterior superior iliac spine, where the posterior wall of the rectus sheath is going to pass in front of the rectus abdominis, this level is called this line is called the arcuate line. Okay, and the clinical significance of the arcuate line is this, that at this site the inferior epigastric vessels that are actually the content of the rectus sheath, the inferior epigastric vessels are actually going to enter the rectus sheath at the level of arcuate line, and then they are going to pass upward, and then they are going to anastomose with the corresponding superior epigastric vessels. Okay. Now there is another point about the linea alba in the rectus sheath, that actually the linea alba is you can say is forming as same as the rectus sheath. The rectus sheath is formed by the aponeurosis of the lateral three muscles of the you can say anterolateral abdominal wall, and the linea alba is also forming by is also a fibrous band that is formed by the aponeurosis of the lateral muscles of the anterolateral abdominal wall. And if the extent of the linea alba, you can see that the linea alba is actually extended from the xiphoid process up to the level of pubic symphysis. Okay, and you can also notice a point here that above the umbilicus, you can see the linea alba is actually you can say a wider above the level of umbilicus, but below the level of umbilicus you can see the linea alba is actually narrowing because it is going to attach to the pubic symphysis. Okay. And there is another point about the posterior wall of the rectus sheath, that the posterior wall of the rectus sheath is actually not attached to the rectus abdominis muscle that is actually present in front of the posterior wall of the rectus sheath, but the anterior wall of the rectus sheath that is present in front of the rectus abdominis muscle is actually quietly strongly attached to the rectus abdominis muscle by these three transverse tendinous intersections. These are actually, you can say, strongly tethering the rectus sheath to the rectus abdominis anterior surface. Now there is an MCQs point that need to be discussed, and that is about the anastomosis of the superior epigastric vessel and the inferior epigastric artery. So here you can see the superior epigastric artery, this red artery, Okay, this red artery is actually behind the rectus abdominis muscle. This red artery is actually the superior epigastric artery, and this superior epigastric artery, I already told you, that is in turn the branch, or you can say the terminal branch of internal thoracic artery. We have discussed this in the thoracic part. So the superior epigastric artery is a terminal branch of the, you can say, the internal thoracic artery, and internal thoracic artery is in turn the terminal branch of the subclavian artery. Okay, and same time the inferior epigastric artery is actually in turn the branch of the external iliac artery, and external iliac artery is actually giving rise to the inferior epigastric artery just above the level of inguinal ligament. That means you can see that there is anastomosis between the inferior epigastric artery and the superior epigastric artery, and you can also discuss this, or the examiner can ask this, that the anastomosis in the rectus sheath is actually between which two main arteries, that is the subclavian artery and the external iliac artery, because in turn the external iliac artery is giving rise to the inferior epigastric artery, and at the same time the subclavian artery is in turn giving rise to the superior epigastric artery. So you can also say that it is the anastomosis between the subclavian and the external iliac artery. Now let's discuss a clinical condition related with the rectus sheath, and that is rectus sheath hematoma. So the hematoma of the rectus sheath is usually uncommon, but it is important because it is often overlooked. Okay, and it occurs, the location where it occurs, it is most common below the level of umbilicus, and the source of bleeding is usually the inferior epigastric vein, or in rare cases you can say the source of bleeding can be inferior epigastric artery, and these vessels may be stretched during a severe bout of coughing. As you already know that rectus abdominis was related with somehow accessory muscle of expiration, and the rectus abdominis is in turn related with the rectus sheath. So you can see, as a result of severe bout of coughing, when we are usually putting too much stress or pressure on our abdominal wall muscles during coughing, so that can also lead to the rectus sheath hematoma and the hemorrhage, or in later months of pregnancy, which may predispose to this condition. And the other cause can be usually a kick or a fall that can lead to a blunt trauma. Okay, and the symptoms that follow the trauma can include the midline abdominal pain, specifically below the level of umbilicus, and the diagnosis you can make it by that you can see a tough fine tender mass that is confined to one rectus sheath, or one side of the rectus sheath, but it is not present on the other side of the rectus sheath. That is usually the diagnostic of this condition of the rectus sheath hematoma. Now let's discuss the collective functions of all the anterolateral abdominal wall muscles. We have already discussed it, so we are just going to overview it. Okay, so the oblique muscles laterally flex and rotate the trunk, that are the external oblique muscles, and the rectus abdominis muscle just only flexes the trunk and it stabilizes the pelvis, and the pyramidalis muscle, you already know that it actually taut the linea alba during this process. Okay, now let's move further. Muscles of the anterior and the lateral abdominal wall, they actually assist the diaphragm during inspiration by relaxing as the diaphragm descends, so that the abdominal viscera can be accommodated, because when the diaphragm will relax, it will convert, it will convert into more dome shaped, and when it is going to convert into the more dome shaped, then there is going to create more space in the abdominal cavity, and that is going to accommodate the abdominal viscera. Okay, now this muscle also assists in the act of forced expiration. You already know that occurs during the coughing and sneezing by pulling down the ribs and sternum. Now how does it actually assist in forced expiration? Because that simply means that how pulling down the ribs and sternum is actually going to help in the act of forced expiration. So actually when they pull down the ribs and sternum, they increase the intra-abdominal pressure. Now how does they increase the intra-abdominal pressure? So when these muscles contract, they act as a girdle. That means they are pulling abdominal wall inward and compressing the viscera inward, and they are compressing the viscera in the abdominal cavity. And now you already know that the abdomen cannot be compressed, so that inward compression actually forces the, you can say, dome shaped diaphragm that is relaxed at this point, and that relaxed dome shaped diaphragm now moves upward into the thoracic cavity. Now when this compression of the abdominal viscera forces the relaxed dome-shaped diaphragm to move upward into the thoracic cavity, this displacement is going to drastically shrink the volume of the thoracic cavity, and in this way the thoracic cavity volume will drastically decrease and the intrathoracic pressure will increase. That will lead to the forced expiration of the air out of the lungs. Okay. Now another point is that their tone plays an important part in supporting and protecting the abdominal viscera. All the muscles play this role, and by contracting simultaneously with the diaphragm, with the glottis of the larynx closed, that means when the larynx when you are not breathing, that means when your larynx is closed, when there is a contraction of the abdominal muscles, then there is going to be an increase in the intra-abdominal pressure, and when the expiration is not happening, then that increase in the intra-abdominal pressure when the larynx is closed is going to help or assist in micturition, defecation, vomiting and parturition to move the fluid or substances out of the body, or you can say material out of the body, because it is going to move from the high pressure to the low pressure. So when the intra-abdominal pressure raises, that is going to assist in micturition or defecation or other reflexes. Okay, but when the larynx is open, then it is going to help in the expiration. Okay. So that was the point. And the other next thing is about the nerve supply of all the muscles, and that we have already discussed in detail separately with each muscle. Now let's just also discuss a general clinical note related with the abdominal muscles and the abdominothoracic rhythm. Actually, the point we are going to discuss here is the abdominothoracic rhythm. So you all know that when the abdominal muscles contract and relax with respiration, the abdominal wall actually conforms in you can say a space to accommodate the abdominal viscera. Now what happens that normally during inspiration, when the sternum moves forward and the chest expands during inspiration, the anterior abdominal wall also moves forward. That means there is a simultaneous movement of the sternum and the chest and the abdominal wall, anterior abdominal wall, and that simultaneous movement is called the abdominothoracic rhythm. Now when this abdominothoracic rhythm is disturbed, then there will be either the abdominal wall will remain stationary, or either it will contract as a result of a reflex caused by the anterolateral abdominal muscles, and that is actually a clinical condition. Now there is also a clinical condition discussed, that is visceroptosis. Now you all know the shape of the anterolateral abdominal wall depend on the tone of muscles. Now a person who has good exercise or good diet will have a good tone of anterolateral abdominal wall, but a middle-aged woman who is actually multiparous, she is oftenly incapable of supporting her abdominal viscera, and that means the lower part of her anterior abdominal wall is actually protruding forward in most of cases, that condition that is the protrusion of the anterolateral anterior abdominal wall, and that is actually a physiologic condition that is called the visceroptosis. So the book is saying that we shall not confuse the visceroptosis with the abdominal tumor, because in abdominal tumor there will be also a protrusion of the lower part of the anterior abdominal wall, such as in ovarian cyst, or either the protrusion of the anterior abdominal wall can also occur in case of the excessive accumulation of fat in the fatty layer of the superficial fascia. Okay, so that was all about the anterolateral abdominal wall muscles and the rectus sheath. So the anterolateral abdominal wall muscles are actually completed here.